Hello and welcome. Ever wondered what happens to that sugary drink or starchy meal after you consume it? Your body embarks on a complex, beautifully regulated process to turn that food into energy. But what happens when that process breaks down today? We'll explore the core concepts of chemical pathology, focusing on how the body manages carbohydrates, what goes wrong in diabetes, and we'll take a look into the fascinating world of inborn errors of metabolism. This is the essential knowledge you'll need for your exams and clinical practice. First, the basics of carbohydrate metabolism. Carbohydrates are a primary source of energy for the body. They're broken down into simple sugars like glucose, which is then absorbed. In a healthy person, blood glucose is tightly controlled, usually between 70 and 110 milligrams per deciliter. This balancing act is managed by several key hormones. You have hormones that raise blood glucose, like glucagon, cortisol, and epinephrine. But there is only one hormone that lowers it: insulin. Once glucose is in the bloodstream, the body has three main options for it. Use it immediately for energy through a process called glycolysis. Store it in the liver and muscles as glycogen for later use, which is called glycogenesis. Or, if glycogen stores are full, convert it into fat, in the fasting state, like overnight. The liver works to keep your blood sugar stable, especially for your brain, which relies on glucose. It does this through two main processes: glycogenolysis, which is the breakdown of stored glycogen, and gluconeogenesis, which is the creation of new glucose from non-carbohydrate sources like proteins and fats. Now, what happens when this system fails? This brings us to diabetes mellitus, a disease caused by an absolute or relative deficiency of insulin, leading to high blood sugar, or hyperglycemia. Without enough insulin, the body can't use glucose properly. This leads to a cascade of problems. First, hyperglycemia. If blood glucose levels rise above the kidney's ability to reabsorb at a point called the renal threshold, around 160 to 180 milligrams dl, the excess glucose spills into the urine. This is called glycosuria. High concentration of glucose in the urine pulls water out with it, causing an osmotic diuresis. This leads to excessive urination, or polyuria, which in turn causes dehydration and excessive thirst, known as polydipsia. Because the cells are starved for glucose, the body starts breaking down fats for energy at an accelerated rate. This process produces acidic byproducts called ketone bodies. An accumulation of these ketones leads to diabetic ketoacidosis, a life-threatening medical emergency where the blood pH drops to dangerous levels. Diabetes is broadly classified into a few main types. Type 1 diabetes, which accounts for about 10% of cases, is an absolute insulin deficiency. It usually has an abrupt onset in children and young adults, who are often described as ketosis-prone. Type 2 diabetes accounts for the other 90%. This is a relative insulin deficiency, often caused by the body's cells becoming resistant to insulin's effects. It has a much more gradual onset, is strongly associated with obesity, and patients are generally not prone to ketoacidosis. Finally, there's gestational diabetes, which is first diagnosed during pregnancy. So, how do we diagnose and monitor diabetes? The American Diabetes Association has clear criteria. A diagnosis can be made with a fasting blood glucose level greater than 126 milligrams dl on two separate occasions, a random glucose level over 200 milligrams dl in someone with classic symptoms, or a 2-hour result over 200 milligrams dl on an oral glucose tolerance test. For long-term management, the most important test is the glycated hemoglobin, or HbA1c. Glucose in the blood naturally attaches to hemoglobin inside red blood cells. Since red blood cells live for about 120 days, the HbA1c level gives us a snapshot of the average blood glucose control over the past 2 to 3 months. It's an invaluable tool for assessing a patient's risk of long-term complications. For shorter-term view, we can measure fructosamine, which is glycated albumin and reflects glucose control over the last 2 to 3 weeks. Beyond diabetes, there's a whole category of rare but important genetic conditions known as inborn errors of metabolism, or AIMS. These are inherited disorders where a specific enzyme or transporter in a metabolic pathway is defective. This creates a metabolic block, leading to the buildup of a toxic substance or the deficiency of a needed product. Let's look at a few classic examples. In disorders of amino acid metabolism, we have phenylketonuria PKU. Here, a deficiency of the enzyme phenylalanine hydroxylase causes phenylalanine to accumulate, leading to severe brain damage if untreated. It's known for causing a characteristic mousy odor in the urine. Another is maple syrup urine disease, a defect in the breakdown of branched-chain amino acids, which gives the urine a sweet smell and causes neurologic deficits. In fatty acid oxidation disorders, the body can't break down fats for energy. The most common is MCAD deficiency. This can be life-threatening, causing severe hypoglycemia and lethargy, especially when a child is fasting or ill. Finally, in carbohydrate metabolism disorders, a key example is galactosemia, due to a missing enzyme. Infants cannot convert galactose from milk into glucose. This leads to the buildup of galactose, causing jaundice, liver failure, and failure to thrive. The world of chemical pathology also includes disorders of other key substances. Disorders of protein metabolism can be acquired, such as the impaired production of proteins in liver disease or the massive loss of protein in kidney diseases like nephrotic syndrome. Disorders of uric acid metabolism can lead to hyperuricemia, or high levels of uric acid in the blood. When uric acid levels exceed its solubility, it can crystallize and deposit in joints, causing the intensely painful inflammatory condition known as gout. And finally, the metabolism of minerals like calcium and phosphate is tightly regulated by hormones like parathyroid hormone and vitamin D. High calcium, or hypercalcemia, is most commonly caused by primary hyperparathyroidism or malignancy. Low calcium, or hypocalcemia, is often associated with chronic kidney disease or hypoparathyroidism. From the daily regulation of blood sugar to the rare genetic defects that disrupt our fundamental biochemistry, chemical pathology provides a molecular window into our health. Understanding these pathways is the first step toward diagnosing and managing these critical conditions. Thank you for joining me. Stay curious, and we'll see you in the next video.